Hello friends, so today I am going to be doing your content review video for the week. I was looking at your guys' conference from this week and y'all did a lot of material, so I'm not 100% sure how this is gonna go. I'm gonna do at least spinal cord injury, probably inflammatory conditions, and head injury because I feel like those three I don't have as much information, and then I might do a separate video for ICP just because I feel like that's a really important topic, and if you can understand ICP, you'll do really well in the exam. I feel like ICP, I remember there being several questions, whereas I don't remember there being as many about the topics I'm going to do here. So I apologize if it kind of goes all over. The other thing that I wanted to say is I noticed that Dr. Schneider is using different PowerPoints than he did with us. So there is a little bit of, I don't want to say discrepancy, but like there's some stuff that he has in his PowerPoints that we didn't talk about, so I don't have notes on that. So like for instance, with spinal cord injury, like looking at his PowerPoint, so like syndromes associated with incomplete SCIs, we didn't talk about that at all. So like central cord syndrome, anterior cord syndrome, Brown-Séquard, cauda equina, I literally don't know what those are. Cauda equina, I do, excuse me, I do know a little bit about because of AMP. That's the horse's tail. But I did look them up and I tried to see if they were in ATI, and I don't see anything in ATI on them. So my advice, my advice would be to just go from the PowerPoint and use your book. One thing you might have noticed is that Dr. Schneider, his lectures go really hand in hand with the textbook, like almost word for word sometimes. So I would just use your book. I mean, I don't know if I'm gonna go over that just because I don't know anything other than what's on the slides. So that might be something that I'll do a little bit of research on, and if it's gonna be on your exam, I'll look up and provide more information to you guys, but if that makes sense. As always, if you have any questions about anything, don't be afraid to reach out to me. I've had several of you reach out to me already, and that's great. I'm always here to help. Term 5 is pretty low key, so it's really just, some busy work and my preceptorship and work. So I do have my preceptorship and work Friday, Saturday, and Sunday this weekend, so I might be a little bit slow to get back to you, but I will get back to you at some point. Okay, so I have so many tabs open. Let me find, okay, so spinal cord injury. So I'm gonna kind of bounce back and forth between what I have on my notes and then the PowerPoint. And if there's something that I don't talk about, like I said, feel free to reach out for me. Those syndromes are the only thing I'm pretty sure in this PowerPoint that I don't have notes on. Okay, so spinal cord injury. Spinal cord injury, pretty self-explanatory as to what it is. It's just any sort of injury to your spinal cord. It's usually caused by trauma. Motor vehicle accidents are the number one cause, but it can also be caused from like flexion injuries. So when your head goes forward, hyperextension injuries, which is when your head goes back, flexion rotation, extension rotation, really just any awkward movement of your neck can cause a spinal cord injury. So there's a primary injury, which would be something like trauma, so a direct hit to the head, a diving injury that compresses the cord, something like that, whereas secondary injury is more over time, so that's going to be more progressive and it occurs after an injury. I am so sorry, I don't know why I'm so hoarse. Maybe because it's morning. Secondary injuries is when you're going to be worried about hemorrhage, hypoxia. You're going to be worried about an increase in your lactate, inflammation, cell death, and permanent damage. And so it's really just like anything else, I feel where, I know we have this with concussions too. So you can have a primary injury, and then there's a secondary injury going on in the background that we don't always know about until it's too late. And so that's why it's so much worse, is because we don't catch it as fast as we should. The whole pathophys, etiology, whatever you want to call it, behind spinal cord injuries is there's bone displacement, interruption of blood flow, there's traction on the cord, and even penetrating trauma is possible. And so any or all of those are going to cause issues with function and can be permanent or temporary. Yeah, and I know Dr. Schneider has a pathophys map on his slide that's essentially just really in depth, but that's essentially what I just said. Okay. Talked about that. So you can classify spinal cord injuries on a couple of different things. It can be on the level of injuries, so what level does it affect skeletally or neurologically, the mechanism of injury, that's what I talked about with flexion injuries, hyperextension, that sort of thing. And you can also classify it on the degree of the injury, so if it's complete or incomplete. And that's where Dr. Schneider starts getting into the syndromes associated with it. So really all I have is it can be complete, incomplete, which is self-explanatory as to what that is. Obviously, they're both pretty bad and they can both have lots of different effects. You can also classify, like I said, based on the level of the injury. So is it in the cervical? Is it thoracic, lumbar, sacral? So you probably remember from A&P, this is your thoracic, and then your cervical, sorry, and then thoracic is in the middle, lumbar is at the bottom, and then sacral is at the very bottom. One thing that I have highlighted that I'm sure you guys talked about, but I'm also pretty positive will be on your exam in some way, is that when you have a spinal cord injury, it affects, if you have a complete lesion, it's going to cause you to lose function below the injury, not above, below. So if you have a complete tear at C4, it's going to affect everything below that, which is why cervical injuries are so bad, because they pretty much just affect everything. So I don't really know. I'm going to come back to that. Okay, so next he has spinal shock and neurogenic shock. So these are just two things that can happen as a result of spinal cord injury, and you guys are going to have a whole shock presentation that's a part of this unit as well, so you might talk a little bit about that during that class as well, but basically these can both happen. So spinal shock, I have the signs and symptoms are going to be, you're going to have hyporeflexia, so decreased reflexes, you're going to have a loss of sensation, your muscles are going to go flaccid below the injury, very important, and it can last months to days, or days to months, I guess. And you're also going to have a hard time with thermoregulation, so you might not be able to tell what's hot, what's cold. Yeah, that's what I have on spinal shock. And then neurogenic shock, I have a lot more information on. So neurogenic shock is a type of distributive shock, and this can happen from a couple different things. So it can happen from spinal cord injury, head trauma, epidural, but usually, and I have this highlighted, usually it's from a high thoracic injury, so above T6. Yeah, above T6. And so what this does is it causes a loss of your sympathetic nervous system, and usually this occurs within 24 hours after a spinal cord injury. And so what happens is there's a vasodilation in your periphery, which causes venous pooling and decreased cardiac output. This is very life-threatening because you're going to have hypotension and bradycardia. Those are like your two key factors. And sorry if I'm looking down. One of the ways I study is I would make like little cheat sheets for most of the disease processes because I'm somebody that I have to write out my notes. So I'm looking at that because it's more colorful. Yeah, that's what I have. But hypotension, bradycardia, that's going to be like your biggest signs and symptoms, like tell all. And so you want to monitor that. There's also, like I said, going to be loss of temperature regulation, edema, and like I said, venous pooling, cardiac output's going to be decreased, and it's usually a T6 or higher injury. I don't know if you guys talked about this as much. You might talk about this a little bit more when you go into shock and start talking about all the different kinds, but with neurogenic, you're going to have warm extremities, but you're going to have a cool body. And the reason for that is, like I said, you have venous pooling and peripheral vasodilation. So basically, everything on the peripheral end is going to vasodilate, which is going to cause that warm feeling. As for treatments, so you're going to want to treat the BP and the bradycardia. So for the BP, you can use your vasopressors, which, remember, those are anything that end in INE, so like epinephrine, for example. And then like atropine can be used to treat the bradycardia. You're also going to want to immobilize the spine and look out for like pressure ulcers, DVTs, PEs, anything that can be caused from just like not moving. All right, moving on. Diagnostics for spinal cord injury. I have a CT as your golden standard because it can tell you more about the stability of the injury, the location, degree, whereas like cervical x-rays, so you can use that in an emergency situation when you don't have a CT, but it's hard to visualize from C7 to T1. You can also use an MRI to look at soft tissue and neuro changes, especially if there's a worsening neuro status. Okay, so then really everything else that I have on spinal cord injury is on emergency management, so like your nursing interventions, and then autonomic dysreflexia, which I know there was questions about that on the exam. That's very important to understand. So I'm going to go into, like I said, I'm not going to talk about the syndromes associated with incomplete SCIs. I would say just know what's on those slides, know what you guys talked about in class, and if you have any questions or if you want me to look that up, if Dr. Schneider ends up telling me that that's going to be on your exam, I'll do some research and make sure that I can give you guys information about it. Okay, so emergency management. This is the big part about SCIs. So if there's a C-spine injury, really if there's any sort of cervical or not just cervical, but any spinal cord injury, you want to stabilize your C-spine because, as I talked about earlier, if you have a C-spine injury, anything below that is going to be affected, and also your C-spine relates to your airway. So by stabilizing your C-spine, you make sure that you can stabilize that airway. This is very important. I know Gerald's talked about this too, but I have this highlighted. If you have an injury above C4, it's gonna impact respiratory function, and then below C4 can cause hypoventilation. So just kind of be aware of that you worry about cervical injuries because of airway and respiratory function. Very, very important. So with that being said, you want to watch for oxygen, worry about that, watch their O2 stats. You might need nasal cannula or even a non-rebreather mask. You want to always look for other injuries. Like I said, if they go into neurogenic shock, that's when you're going to be watching their BP and their heart rate and administering those medications that I talked about. You also are going to want to establish IV access to large bore IVs to infuse normal saline or lactated ringers, control bleeding. So if you have an injury above T6, then that can impact the that's when, like I said, I talked about that with neurogenic shock, but when you have an injury above T6, that's going to lead to SNS problems, sympathetic nervous system problems, and so you're going to have bradycardia and you might need atropine, poor respiratory function above C4, and then ventilation, hypoventilation below C4. So the respiratory things and then the bradycardia, I have those all three highlighted, so I would be aware of that. Already talked about vasopressors, and then you're just going to start doing your neuro or your management for anybody that's bedridden. So, making sure you're changing positions every 2 hours, monitoring for ileuses, making sure that they're using their IS if they're able to, monitor for pressure ulcers, vital signs, LFC, urine output, all of those things. You want to keep them warm. If they have no gag reflex, you're going to intubate them. And if they have thoracic and lumbar injuries, so these tend to be less intense because especially if it's below T6. If it's above T6, we already talked about that, you're going to have heart rate issues. But if it's below T6, you're not going to have bradycardia, you're not going to have the respiratory compromise. So you really just want to treat the symptoms based off of what you see. Neurogenic bladder can also occur, and so that means that patients can't void normally, so they might need a Foley catheter. They might also have to be straight cathed. So I actually got to straight cath a patient who had neurogenic bladder at clinical, so that's something to be aware of. You might have to bladder scan them like Q4, Q6, just to make sure that their bladder doesn't get too full. Okay, so let me see what, yeah, that's pretty much what Dr. Schneider has. Okay, the other thing he has that we didn't really talk about was the traction, but I actually can talk about that because I work, I think I've mentioned this many times, but I work on orthopedics at Barnes, and so I see this like every shift, so I can actually talk about that. Okay, so that's really what I have for like clinical manifestations, nursing interventions, that sort of thing. These nursing interventions are going to be like drilled in your head because they go with other things, not just spinal cord injury. The next little section that I have is about stabilization after an injury. So like I said, if they have any sort of spinal cord injury, even if you don't think if it's a cervical injury, you're gonna stabilize the C-spine. Very important. There will probably be a question on that. You're gonna use the C-collar. You might put them on the backboard with the straps, but you want to do that immobilization because you don't want them to like move and then have it get worse or compromise their respiratory function. After your patient is stabilized, that's when you can obtain a history. You can go through their assessment, get their muscle groups, start touching and seeing if they can feel pain. You usually want to start at the toes and work your way up. Do they have any LOC changes? And one thing that's hard is that with spinal cord injuries, your only sign of internal trauma and hemorrhage could be an increasing heart rate and BP. So like we talked about with neurogenic shock, usually you see the opposite. You see hypotension and bradycardia. So if you start to see an increasing heart rate and an increasing BP, that should be a red flag that there's maybe a hemorrhage going on. But bottom line is these patients are going to be on continuous monitoring. You want to make sure that their systolic is above 90, and dopamine can do this. Vasopressors, that's why we're going to be giving those once again. They might go to surgery if there's evidence of cord compression, neurodeficits, penetrating wounds. And the surgical procedure that we talked about relating to this is a laminectomy, which basically just opens up your spinal cord to relieve compression. And so it removes the lamina, which is the part of the spinal cord, or the part of the vertebra that covers the spinal canal. Okay, really quickly, talking about immobilization and skeletal traction. So I know that Dr. Schneider has pictures of like the halo and those types of devices. Like I said, I have seen patients with that numerous times. There's one that I can think of right now that's coming to mind with her halo. And then I actually had a patient this past week. I'd never had this type of situation before. So she was in a halo, but she was also hooked up to traction. So she had the halo on, and then there was a little like S hook, and it went to like a pulley system and was attached to weights. And so the biggest thing whenever you have a patient in any sort of hardware like that is pin care. Pin care, pin care, pin care. You guys will talk even more about that with orthopedics, but there's a very high chance of infection at any site of pins or tongs or anything. And I know Dr. Schneider has a slide on that. And so you want to cleanse that at least twice a day. You can also put ointment. So like when I was working on Sunday, the nurse and I did pin care. I think we did it 3 times. And so she would do the more like heavy duty stuff. You use like half strength peroxide, or you can even use CHG. But like for me, I just took a normal saline syringe and I sprayed it on like what are those called? Just like a Q-tip almost. And then I would go around the pins, and like she had dried blood, so it just kind of helped to get all that gook out of there. So very, very important. Just some other things. I don't know if you guys talked about this with traction or anything. Weights never touch the floor, ever. So when you're transferring a patient in traction, it's almost always a 2-person job. So anytime that we got her up, it was the nurse and myself, and the nurses are the ones that control the weights. So I never touch that since I'm a tech. Really good pin care. They're also going to be very top heavy if you have patients in traction. So like when they stand up, don't be surprised if they kind of like lean forward. So just like make sure that you're kind of in front of them. And then also they shouldn't be bending their neck. They're going to want to, and they're going to try. So you might have to put a soft collar on them when they stand, but you want to make sure that they try not to bend their neck, because that's going to hurt their C-spine even more. Okay, so that is that. So that's pretty much everything that I have on spinal cord injury. So now I'm going to talk about autonomic dysreflexia. Let me really quickly go through his slides. I know his PowerPoints sometimes go like back and forth between stuff, which is fine. It just reiterates it. But ileus, yeah, so they might need an NG tube, fluid electrolytes, nutrition, 72 hours, high protein, high calorie. If there's ever a question and it's like, what type of diet? High protein, high calorie is almost always the answer. They might need TPN. Catheter, we talked about that. You want to increase their fluids. That's why they're on the 2 large bore IVs with normal saline and lactated ringers. Like I said, they might need to be straight cath, bladder scan to Q4, Q6. Might need a suppository, fluid fiber, that sort of thing. Okay, so autonomic dysreflexia. So this is massive uncompensated cardiovascular reaction mediated by the sympathetic nervous system after stimulation or sensory receptors below the level of the spinal cord injury at T6 or above. That's like the technical definition of it. But essentially what it is there's something that causes you to have this response. Usually it's to like pain, increased pressure, And like I said, it's above T6, but it's just when the sympathetic nervous system basically goes berserk. So like very common causes would be a full bladder, bowels, like if you're constipated, because basically what it does is that full bladder, that bowel obstruction, it goes to the brain, but because you have a spinal cord injury, it gets stopped. And so then that stimulates the sympathetic nervous system and just like everything goes crazy. So your airway will relax, open up, your heart rate's going to decrease, and your BP is going to be insanely hypertensive. That's like the first sign, the telltale sign. I mean, it can be as high as like 200 to 300 because there's so much pressure and it just can't go anywhere because of that injury. There's going to be flushing, sweating, nasal congestion, headache because the vessels are going to be relaxed and constricted, sweating, that sort of thing. Restrictive clothing, that's another thing. So if they have a gait belt on, I know we had a question on this on the exam, and it was like, you have a patient who was left in bed with a gait belt on, and you walk in and they're like sweating, their blood pressure is like 200 over 100. What do you do? The first thing that you always want to do is you want to remove the stimuli that's making them go into this state. So if they have a full bladder, straight cath them. If their Foley is kinked, flush it with normal saline, try to get it unkinked. If they're covers, it can even be as simple as having like sheets and covers piled up underneath them. If that's the case, remove them, smooth them out. And then what you're going to try to do is you basically just have to remove that noxious stimuli and just continue to monitor them. It's as straightforward as that. And once you remove the stimuli, they should start to go back to normal. Very, very important. You will probably have a question on that. Okay, I have a few more nursing interventions. I think we just talked a little more about them at the end of the class, so that's why. But I think I've already mentioned these. Yeah, you want to maintain systolic above 90. DVT, pressure ulcer, PE risk, I think I mentioned that, but you just want to administer your anticoagulants, so like heparin, Lovenox. You might have to give enemas, yada yada. Yeah. Range of motion, you might have to do that for them because they probably can't get out of bed. Yeah, okay, so that is everything I have on spinal cord injury and autonomic dysreflexia. I know Dr. Schneider has some stuff about sexuality. Really, the only thing I remember talking about is how fertility usually isn't affected. But I don't remember talking about anything else with that. As always, with your gero patients, usually they have increased mortality, increased adverse effects, usually increased incidence, that sort of thing, and they might have to stay at the hospital for a longer period of time. So, okay, we're only at 20 minutes. Nice. I am going to pause this, get my other stuff set up, and we will get going. Okay, so like I said, if you have any questions about spinal cord injury, autonomic dysreflexia, neurogenic, spinal shock, reach out to me. And hopefully, I think I've mentioned this before, but I feel like sometimes my notes go all over. So hopefully you're able to keep it straight forward, and hopefully what I talked about helps. I'm sorry I don't have notes on those incomplete spinal cord injury, what was I saying? Oh, on those syndromes, but I will make sure to get information for you guys if you need it. So next, I am going to talk about head injury, and then we're going to go into inflammatory, And like I said, I think I'm going to do a separate video for ICP. So head injury is going to be any trauma to the skull, scalp, or brain. Traumatic brain injuries, usually they're in younger males, and trauma is like the number one risk. And so one thing that I have highlighted, I don't remember there being a question about it, but I have it highlighted, is so there's 3 points with head injury that there's a high potential for mortality or a poor outcome. So immediately after the injury, and usually that's due to just like direct trauma, a massive hemorrhage, that sort of thing. So that's the first point. And then within 2 hours after the injury, because basically like internal bleeding just keeps going, progressive worsening of the injury, that sort of thing. And then 3 weeks after the injury due to multi-system organ failure. Like I said, I don't remember there being anything on that, but I think that that's just important to understand. Going into skull fractures, which is pretty common with head injuries. So you guys probably remember talking about this with Gerald's, because there's 2 like really big signs and symptoms of skull fractures. So with the basilar skull fracture, so that's at the base of the skull, and usually it presents over a couple hours. And that's when you have the raccoon eyes, which is periorbital ecchymosis. So that's just like the bruising around your eyes. And then the battle signs, which is post-auricular ecchymosis. So that's like behind the ears. Very important to understand that. I have that highlighted. So you need to know that raccoon eyes is periorbital ecchymosis. Battle signs is post-auricular ecchymosis. And once again, I actually had a patient last Sunday who had a basilar skull fracture, and like he had the raccoon's eyes and the battle signs. They also might have a CSF leakage, so cerebral spinal fluid leakage, due to like a tear because of their fracture. So if they have rhinorrhea, that's going to be leakage from the nose. If they have otorrhea, that's from the ears. And so if you ever see a patient that has like a clear liquid coming out of their nose or their ears, you want to test it immediately for spinal fluid. So you're going to do either the halo sign, which is when you put it on gauze and the blood will coagulate in the middle, and then you'll have a ring of spinal fluid around it. Or you want to do glucose testing. And so it's positive if you just test the spinal fluid and it's positive for glucose. And once again, you probably remember that from patho, because I remember we talked about that. So if they have cerebral spinal fluid leakage, it's really important to be able to do those signs to tell that, because if they have that leakage, they have an increased risk for meningitis, so you want to get them on antibiotics ASAP. So that is that. So there's different types of head injuries. You have diffuse, which are more generalized, so like it's like a concussion. You could have focal, which is more localized, like a contusion or a hematoma. You're going to use the Glasgow Coma scale to evaluate. So remember that goes from like a 3 to a 15. So a minor head injury, they're going to be 13 to 15, nice and awake, able to understand you, respond. Whereas like 9 to 12 is in the middle. Anything less than 8, remember, less than 8, intubate, that's very severe head injury. I have, so lacerations are tearing of the brain tissue, usually due to like an open, like penetrating injury, or just like an open fracture. I have a contusion. So contusion is just like a bruising of the brain, usually with a closed head injury. So with those two, so lacerations are very important because you can have a hemorrhage with a laceration. I mean, A laceration just means it's a cut. You can have that anywhere. So you're worried about hemorrhage, and that means that there could just be blood pooling in the brain. So one thing I've highlighted, and I remember there being a question on, is any time that you have somebody who has had a head injury and they have fixed pupils, that is a medical emergency, because that means that there's blood filling in the brain. So if you see that, you're going to call the provider. Like, that's an emergency. And if they have a laceration that's doing that, they might have to have surgery. So a contusion, they can also have hemorrhage, infection, edema. And one thing that I have highlighted, and I feel like we talked about this, so I think a lot of people missed it, that's why. So contusions are, if they have a brain contusion, they're likely to be admitted to the hospital because it can rebleed. Whereas if they have a concussion, hold on, I want to make sure that I get this right. Whereas if they have a concussion, they can usually go home. They don't have to be admitted. And I'm pretty sure we had a question on that, and I think a lot of people missed it. But yeah, I have highlighted that with contusions, they're likely to be admitted to the hospital because it can rebleed at any time, and so you want to be there for them if that happens. And if you ever have somebody with a brain injury, head injury, you always want to see if they're on anticoagulants, because obviously if they're on heparin, for example, you're going to want to get them off, and you might have to administer the antidote because that could just increase their chances of bleeding. You want to monitor for seizures, especially with contusions, because they could happen at any time. So then concussion. So concussion, otherwise you might hear it as like the contra-coupe, don't know if I'm saying that right, injury. Basically just when you go back and go forward. This type of injury, you're really worried about a spinal cord injury because, like we talked about with spinal cord injuries, that can be caused from flexion or hyperextension, which is what a contra-coupe injury is. Whereas a concussion is more of like sudden, and you may or may not lose consciousness with either of these injuries. So that's very important. So basically the brain is just moving within the head, and usually they're pretty severe, and so you want to watch them, but they're not going to have to be admitted unless they're having like visible signs and issues. Next thing, I don't remember there being any questions on epidural hematomas and subdural hematomas, but I still have notes on it. So epidural hematoma, that's bleeding between the dura and the inner skull fracture, and this is an emergency. So if it's a venous blood flow, that's very slow, whereas if it's an arterial bleed, that's very rapid because it's pumped from the heart. And so usually it's the middle meningeal artery that's torn for an arterial bleed, and I have that highlighted. Usually with an epidural hematoma, I have this highlighted too, you have an initial period of unconsciousness, and then you're going to have brief lucid intervals followed by decreased LOC over time. One thing I remember we talked about in Gerald's with epidural hematomas is they can be really dangerous if they're venous, because these are going to be the people that you send home, and then as the venous blood flow, or as the venous bleed continues, it just becomes more severe, and usually they'll just like die at home. They could also have headache, nausea, vomiting, but you want to have rapid intervention to prevent a hematoma or increased ICP. So they might have to have a craniotomy, Burr's holes, which is when you just like poke a hole in the brain essentially, or a drain. A subdural hematoma is bleeding between the dura mater and the arachnoid. The most common source is the veins that drain the brain surface into the sagittal sinus, but it can be arteries as well. So if it's acute, it's going to manifest 24 to 48 hours after the injury, and your symptoms are like increased ICP. So you're going to have LOC changes, you might have vomiting, headache, that sort of thing. You're going to have ipsilateral pupil dilation and fixation if it's really severe. So remember, ipsilateral is like the same side, contralateral is opposite sides. And then chronic is weeks or months after the injury, and this is more common in older adults because they have a larger subdural space due to atrophy. So if you think about how as we age, we have atrophy of pretty much everything, and so that means that it's going to take a little bit of time for them to show their symptoms if they have a chronic subdural hematoma. These present as focal symptoms, so not ICP. So they might be confused, lethargic. That's important, I would say. So acute is going to be more ICP related symptoms, pretty rapid, whereas chronic is not as rapid and you're going to have more focal symptoms. Like I said, I don't remember there being anything on the exam about this, but still important to know and to study. And then intracerebral hematoma is bleeding within the brain tissue. So subdural is between dura mater and the arachnoid, epidural is between the dura and the inner skull, and then intracerebral is within the brain tissue. Diagnosis, CT scan is the best thing to do for any sort of head injury. Talked about that with spinal cord injury as well, but you can also use an MRI for like small lesions, that sort of thing. Your emergency management is going to be really the same thing as like spinal cord injury, so you want to stabilize the C-spine, oxygen via a non-rebreather mask, 2 large bore catheters, control the bleeding, intubate if their Glasgow Coma scale is less than 8. You want to remove their clothing, apply pressure to stop bleeding, maintain warmth ongoing, and you always, 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 I have this highlighted, and want to assume that they have a neck injury if they have a head injury. And I mentioned that with spinal cord injury. That's why you stabilize the C-spine even if they don't have a C-spine injury, because you just never know. You want to prevent secondary injuries. And then after they're stabilized is when you can start to, get your history. Were they taking were they taking drugs? Were they drinking alcohol when the injury happened? That sort of thing. But bottom line is, with really any sort of head injury, your LOC is going to be your best indicator to look at. So do they have altered mental status? Because that might mean something is going on. Do they have an impaired gag reflex? Are they projectile vomiting, incontinence, bruising, battle sign, rhinorrhea, all those things that we already talked about. And then we talked a little bit about and then they might need TPN as well. We talked a little bit about like health promotion, so make sure that you're wearing a seatbelt, going the speed limit, that sort of thing. Wear helmets when you're riding a bike. Home safety to prevent falls in older adults. So you want to have grab bars, good lighting, good shoes, no rugs. You don't want them to fall. So that is everything I have on head injury. So we're cruising right along, 42 minutes, perfect. Okay, the last thing that I'm going to talk about in this little video is going to be inflammatory disorders, which I do not have that much on at all. I literally have 2 pages. So I'm going to do my notes first, and then I'll go back to Schneider's. So inflammatory conditions of the brain, so these can be bacterial, viral, fungal, and they can occur in the bloodstream or in the cranial and spinal nerves. The main one that we talked about is bacterial meningitis. So this can enter the bloodstream, or it can be an upper respiratory infection, and staph pneumoniae and I can't pronounce this, Neisseria meningitis are leading causes. I have that highlighted. Your clinical manifestations are going to be fever, a severe and progressive headache, nausea, vomiting, neck stiffness is a very big one, photophobia, which is like sensitivity to light and like stimulation. That's a very big one. rash, petechiae, that sort of thing. The petechiae, you'll talk about this in peds when you talk about meningitis, but the petechiae are like the little tiny purple like dots. Hold on, my dog wants in here. Okay, sorry, this is Nala. So the reason that you get petechiae, which are those like little tiny like red or like purple dots on like the chest especially, is because so meningitis, like I said, it's usually from bacteria that entered the bloodstream. So what's gonna happen is your cells are gonna burst because of that. Kernig's and Brudinsky signs, I have that as well. So Kernig's is stiffness of the hamstrings, so you're not going to be able to straighten your legs when your hips are flexed. And then Brudinsky is extreme neck stiffness with hip or knee flexion. So I would be able to associate those with meningitis. Diagnostics, you're going to do lumbar puncture, CT scan, blood cultures. You're basically looking for any sort of bacteria. And bacterial meningitis, or really just any type of meningitis, is super important because it can lead to increased ICP, LOC changes, cranial nerve changes, just like really bad infection that you can't control. If they have bacterial meningitis, which is what we're talking about, they're going to be on droplet precautions, so know your droplet precautions. If they become confused and agitated, they might need a sitter. Papilledema is another complication, which is swelling of the optic nerve. Really, so when it comes to meningitis, you're going to want to decrease stimulation, so that could mean lowering the lights, making sure there's not a lot of noise, they're in a quiet room. You're going to want to give them antibiotics, so like ampicillin. I can't pronounce antibiotics to save my life, so antibiotics. They're going to be on bed rest usually. Clear liquids is tolerated. They might need mannitol to decrease the fluid in the brain, which we'll talk a little more about mannitol when we talk about ICP. You want to do eye exams to make sure they're not getting that papilledema. As far as education, you want to teach them early signs of ear infections, elevate the head of the bed, treat the fever and the pain, increase their nutrition, so like they might need TPN once again, and then vaccination for when they're kids. And when you do this cerebral spinal fluid, you're looking for white blood cell count. You're looking at white blood cells, protein, glucose. You're basically looking at the components of the spinal fluid, because if it's bacterial, they are going to have low glucose because the bacteria is consuming the glucose. And you'll talk about that in peds, I know. So then viral meningitis is regular precautions, so you don't need droplet. Usually comes from enteroviruses, and once again, you're going to have the headache, stiff neck, fever, photophobia, and your cerebral spinal fluid. I'm going to look at that as well. And this one's treated based on the symptoms. It's very similar assessment findings and teachings and interventions than bacterial. Really the biggest difference is just bacterial, you have those droplet precautions. So then encephalitis. So this is an inflammatory condition of the brain. It can be caused by various things, but it's usually from a virus that comes from an insect, and it's usually more in the developing countries. So you could have fever, headache, LOC changes, tremors, memory impairment, that sort of thing. You're going to do your regular diagnostics, so like CT, MRI, and then you're going to just manage the symptoms. So if they have an HSV infection, you're going to give them drugs to treat that. If they're having seizures, anti-seizure meds. That's all I have on encephalitis. Rabies, animals are the vector, usually transmitted by saliva. So then symptoms, I'm sure you guys have heard of this, hypersalivation. They're going to be extremely photophobic, so like won't like look at the light at all. Very stiff neck, vertigo, diplopia, hallucinations. And usually you can find it in the saliva, blood, or cerebrospinal fluid. Pretty much always fatal. Yeah, that's all I have on rabies. And then the last thing I have is a brain abscess, which is an accumulation of pus that is walled off and infected within brain tissue. This can come from an infection that's like in the ear or in the tooth. So that's like the biggest piece of education with this, is that if you have any sort of tooth, gum, ear infection, you want to treat it right away with antibiotics. And if you, antibiotics, and then good oral care should always be a thing. Signs and symptoms, same thing: fever, headache, nausea, vomiting, and you're going to treat this with antimicrobials. Okay, so that is all I have on inflammatory conditions. Let me really quickly look at his slides just to make sure. Like I said, I don't remember there being that much. Okay, his PowerPoints like are the same. They're just like a different color. Sorry. But as always, like I said, if you guys have any questions at all, make sure that you reach out to me. Oh, one thing I know I did not mention with basilar skull fractures, but you should absolutely know from Gerald's, because I know she yelled this at us, is never, ever, ever, ever use a nasogastric tube, ever, because it can just like suck your brain. They're not going to sneeze, blow their nose, no nasotracheal sectioning, nothing like that, because you don't want to disrupt what's going on. They should also be have the head of the bed elevated. Yeah, so I'm gonna do a separate video on ICP. I don't know if I'll do that today or if I'll do that more next week. I should probably try to do it today. Sorry guys, I'm just making sure that I got everything. Brain abscess, strep and staph, talked about that. Bacterial meningitis. Yeah, bacterial meningitis is usually fatal if you don't treat it. Nala. So yeah, bacterial meningitis, viral meningitis, encephalitis. Oh, you guys didn't even talk about rabies. Okay, so that is all that I have for you guys today. Like I said, make sure you leave your emails so I can mark you guys down. If you have any questions as we get closer to your exam, I know your exam's a week from Tuesday, so you guys should definitely be hitting the books. If you aren't already, ATI, very good resource. I never used ATI really until term 3, and then term 4 I was very religious with ATI, so be using this. It'll help you guys a lot. But reach out to me if you have any questions, and hope you guys have a good rest of your day.